Welcome, everyone. On behalf of the Centers for Medicare and Medicaid Services Division of Tribal Affairs, I would like to welcome everyone to an All Tribes Consultation webinar. My name is Nicole Pino, and I work for Kaufman and Associates, and I will be your moderator today. Today's webinar is titled Proposed Tribal Exemption from the Four Walls Requirements. Please note this webinar series is supported by a contract awarded by the Centers for Medicare and Medicaid Services. And at this time, I will be turning it over to Rachel.
Hey, good afternoon. Welcome to today's webinar. I'm Rachel Ryan Pedersen, Technical Director in the Division of Tribal Affairs. This webinar is a collaboration between the CMS Division of Tribal Affairs and the CMS Medicaid Benefits and Health Programs Group, Division of Benefits and Coverage. During this webinar, presenters will provide an overview of a proposed tribal exemption from the Medicaid Clinic Services Benefit at 42 CFR 440-90. This benefit requires that services are provided in the clinic, with an exception for furnishing services outside of the clinic to individuals who are unhoused. We refer to this as the four walls requirement. However, CMS recently published a tribal exemption from the Medicaid Clinic Services Benefit in the Hospital Outpatient Prospective Payment System, or OPPS, and Ambulatory Surgical Center proposed rule. The proposed rules were published on July 10th, and written comments are due September 9th. We ask that you follow instructions in the Federal Register notice for submission of comments. Any materials related to this presentation can be downloaded from the Spotlight page of the CMS American Indian and Alaska Native website at go.cms.gov/AIAN. The website link will be added in the chat. We're pleased to be joined on this webinar by Ryan Tisdale from the CMS Medicaid Benefits and Health Programs Group, Division of Benefits and Coverage. I'll now turn it over to Ryan to begin today's presentation.
Thank you, Rachel. As Rachel indicated, my name is Ryan Tisdale. I'm an analyst within CMS's Division of Benefits and Coverage, and I helped write the proposed rule. Sorry, having technical difficulties. Okay. I'm delighted to be here at the All Tribes Consultation webinar to provide an overview of the proposed Medicaid Clinic Services Four Walls Exceptions rule. For our presentation today, I will start with some background, followed by an overview of the proposed rule, and then we will go into a Q&A. Before I go over the content, I would like to note that the policies presented in this deck are not final and are subject to change in the final rule. All comments must be received using the instruction in the published Federal Register document 89 FR 59186. Nothing participants say during this webinar will be viewed as a comment on the proposed rule that is open for public comment. For many of you, much of this information in the background will be a refresher on Medicaid Clinic Services policy, but I think it's still helpful to go over it. The Medicaid Clinic Services Benefit is an optional benefit category, so states can choose whether or not to cover clinic services. Clinic services are defined at Section 1905A9 of the Act and in regulations at 42 CFR 440.90. There are separate benefit categories for FQHC services, RHC services, and outpatient hospital services, which the outpatient hospital services benefit is the benefit category states can cover hospital-based clinic services. Under current regulations, clinic services are defined as preventive, diagnostic, therapeutic, rehabilitative, or palliative services furnished by a facility that is not part of a hospital, but is organized and operated to provide medical care to outpatients, furnished by or under the direction of a physician, and furnished within the four walls of the clinic except for services furnished to an individual who is unhoused. Congress amended the Medicaid Clinic Services Statute in 1987 to specifically create an exception to the four walls requirement for individuals who are unhoused. Following the legislative change, CMS, HCFA at the time, issued a Medicaid Clinic Services rule where we explained that clinic services have always been limited to the four walls of the clinic or a satellite location. In addition, we explained that the exception represents an exception to the four walls coverage requirement and that we interpreted this legislative change as ratifying the four walls requirement by establishing an explicit exception. We reiterated CMS's longstanding interpretation that Section 1905A9 of the Act established a four walls requirement in a FAQ document that we published in 2017 to supplement State Health Official Letter 16002, which is titled Federal Funding for Services Received through an IHS Tribal Facility and Furnished to Medicaid Eligible American Indians and Alaska Natives. Although we learned about it in 2016, CMS recognized in 2017 that IHS and tribal clinics were providing services outside of the four walls, including to individuals to whom the existing statutory and regulatory exception does not apply, and that states were paying for these services at the clinic services rate. CMS then announced a 4-year grace period in a 2017 FAQ to allow IHS and tribal clinics in states to come into compliance with the four walls requirement. The grace period was initially scheduled to end on January 30th, 2021. Subsequently, CMS issued 3 CMCS informational bulletins to announce further extensions of the grace period due to the COVID-19 public health emergency, and then due to the strain of unwinding to regular Medicaid eligibility operations, and as CMS was reviewing the clinic services benefit regulation and four walls requirement. The grace period is currently scheduled to end on February 11th, 2025. CMS has heard from tribes, the TTAG, and the STAC that the four walls requirement will impede access for beneficiaries who receive care from IHS and tribal clinics, and asked CMS to eliminate the four walls requirement for IHS and tribal clinics. In addition, CMS has received some requests from states to allow exceptions to the four walls requirement for clinics that serve vulnerable populations, such as behavioral health clinics. As part of Medicare's calendar year 2025 hospital OPPS and ASC proposed rule, CMS included a proposal to add exceptions to the clinic services benefit four walls requirement. CMS is proposing a mandatory exception for IHS and tribal clinics, and optional exceptions for behavioral health clinics and clinics located in rural areas. The proposed exceptions for behavioral health clinics and clinics located in rural areas are not tribal specific. Comments are due by September 9th and need to be submitted on or prior to that date. CMS is proposing these exceptions to address the concerns expressed by tribes, the TTAG, the STAC, states, and other interested parties. To fulfill Executive Order 13175 by recognizing the United States legal relationship with tribes and by responding to advice and input received from tribal consultation. To fulfill Executive Orders 14009 and 14070 by helping states to strengthen and improve access to clinic services, and to be consistent with our strategies, goals, and objectives to advance health equity and improve access to care for tribal, behavioral health, and rural populations. While we are proposing 3 additional exceptions, CMS continues to believe that the clinic services statute does not authorize broad exceptions to the four walls requirement that have no relation to the current exception or complete elimination of the four walls requirement. CMS is reinterpreting the Medicaid clinic services benefit statute as allowing additional exceptions to the four walls requirement for populations served by clinics if those populations have similar health access issues as the unhoused. The exceptions outlined in the proposed rule follow 4 criteria that mirror the needs and barriers to access experienced by individuals who are unhoused. The criteria are: the population experiences high rates of behavioral health diagnoses or difficulty accessing behavioral health services. The population experiences issues accessing services due to a lack of transportation. And the last 2 criteria are: the population experiences a historical mistrust of the healthcare system, and the population experiences high rates of poor health outcomes and mortality. CMS expects the proposed exceptions to the clinic services four walls requirement to improve access to care for populations targeted by the exceptions. If finalized, the exceptions would authorize states to pay for services furnished under the exceptions at facility-based clinic services payment rates, such as the IHS all-inclusive rate. Because the proposal would authorize payment at the generally higher facility-based clinic services payment rates for the expected services, we believe that it would incentivize providers to provide these services outside of the four walls and thereby meet these beneficiaries where they are located, which will help to ensure access to necessary care. CMS proposes to add an exception to the 4 walls requirement for IHS and tribal clinics at a new 42 CFR 440.90C. This exception would be mandatory for all states that cover the clinic services benefit, only apply to clinics that are owned and operated by IHS, clinics that are owned by IHS and tribally operated, or by tribes and tribal organizations as authorized by the Indian Self-Determination and Education Assistance Act of 1975, and apply to any Medicaid beneficiary who receives services from an IHS or tribal clinic. I'll note that under Section 1903A1 of the Act, the federal government is required to match state expenditures for medical assistance at the Federal Medical Assistance Percentage, FMAP, which is defined at Section 1905B of the Act to be 100% for state expenditures for Medicaid-covered services received through an IHS facility, whether operated by IHS or tribal facilities. Under CMS's long-standing interpretation of Section 1905B of the Act, this 100% FMAP is available only for state expenditures on services received through an IHS or tribal facility by AIAN Medicaid beneficiaries. And state expenditures and services furnished by an IHS or tribal facility to other Medicaid beneficiaries are not matched by the federal government at 100%, but rather at the otherwise applicable FMAP. And this would continue to apply for services provided outside of the 4 walls of a clinic. CMS is not proposing to include facilities operated by UIOs in this proposed exception because it is our understanding that many UIOs currently practice in Medicaid as FQHCs, and there is no 4 walls requirement for the FQHC services benefit. Because Medicaid FQHC services are not subject to a 4 walls requirement under federal Medicaid law, we believe that UIOs are unlikely to need the proposed exception. UIO facilities that provide Medicaid clinic services might qualify as behavioral health clinics or clinics located in rural areas and be exempt from the 4 walls requirement under the optional exceptions. CMS is proposing this exception based on advice and input received through tribal consultation and evidence that the population served by IHS and tribal clinics meet the 4 criteria more than other populations. CMS is proposing that IHS and tribal clinics would be a proxy for the patient population they serve because the entire patient population who receives services from IHS and tribal clinics are likely to meet all or some of the 4 criteria described in the proposed rule, and they serve a clearly identifiable group of Medicaid beneficiaries under IHS statutes and regulations. By taking this proxy approach, our proposed regulation text proposes to apply the exception at the facility level rather than the individual beneficiary level. CMS proposes to add an exception to the 4 walls requirement for behavioral health clinics at a new 42 CFR 440.90D. This exception would be optional for states that cover the clinic services benefit, apply to clinics that are primarily organized for the care and treatment of outpatients with behavioral health disorders, including mental health and substance use disorders, apply to any services furnished outside of the 4 walls by a behavioral health clinic, including non-behavioral health services such as physical health services, include behavioral health clinics that are recognized nationally, such as community mental health centers, and other behavioral health clinics organized in the state. And if this proposal is finalized as described, states that choose to adopt this exception would describe the types of behavioral health clinics such exception applies to in their Medicaid state plan. We recognize that the types of behavioral health clinics within a state may vary, so we are not proposing to limit this exception to specific types of behavioral health clinics. However, to be considered a behavioral health clinic under this proposed exception, the clinic would have to be primarily organized to treat outpatients with behavioral health disorders, regardless of the patient mix of the clinic. CMS is proposing this exception based on evidence that indicates that an exception to the clinic services 4 walls requirement could be warranted based on state-specific circumstances for behavioral health clinics, as these clinics might primarily serve a patient population that may be more likely than other groups to meet more of the 4 criteria. CMS is proposing that the behavioral health clinics would be a proxy for the patient population they serve because we believe it would be too operationally burdensome to require that clinic services be provided specifically to individuals with a behavioral health disorder, and it is our understanding that behavioral health clinics generally serve a patient population that consists primarily of individuals with behavioral health disorders. By taking this proxy approach, again, our proposed regulation text proposes to apply the exception at the facility level rather than the individual beneficiary level. CMS proposes to add an exception to the 4 walls requirement for clinics located in rural areas, a new 42 CFR 440.90E. This exception would be optional for states that cover the clinic services benefit, apply to clinics located in rural areas, and not apply to clinics that are RHCs, since RHCs have their own mandatory Medicaid benefit category that does not have a federal Medicaid 4 walls requirement. CMS is proposing this exception based on evidence that indicates that an exception to the clinic services 4 walls requirement could be warranted based on state-specific circumstances for clinics located in rural areas, as these clinics might primarily serve a patient population that may be more likely than other groups to meet more of the 4 criteria. CMS is proposing that clinics located in rural areas would be a proxy for the patient population they serve because CMS believes it would be too operationally burdensome to require that clinic services be provided specifically to individuals who reside in rural areas, and it is our understanding that clinics located in rural areas generally serve a patient population that consists of primarily individuals who reside in rural areas. Like the other proposed exceptions, by taking this proxy approach, our proposed regulation text proposes to apply the exception at the facility level rather than the individual beneficiary level. There are many federal and state definitions of rural for various programs, and no single definition precisely identifies all rural areas. Some rural definitions may categorize areas that are generally recognized as suburban as rural, while other definitions may classify sparsely populated remote areas as urban. CMS did not include a definition of rural in this proposed rule, but is considering defining the term in the final rule. CMS is considering several approaches to defining rural for the final rule. These approaches that we were considering include the census definition, the Office of Management and Budget definition, HRSA's Federal Office of Rural Health Policy definition, allowing states to adopt a definition of rural that is adopted and used by a federal governmental agency for programmatic purposes, allowing states to adopt a definition of rural that is adopted and used by a state governmental agency with a role in setting rural health policy, or not adopting any definition of rural, which would allow a state that elects this exception to choose any definition of rural that can be linked to the 4 criteria we described in this proposed rule and meets its program needs, but would not identify the definition in the Medicaid state plan or submit it to CMS for review and approval. In the proposed rule, we list out various pros and cons to each of these options, and we invite comment on which approach to defining rule we should adopt if the rule is finalized. CMS is also proposing to codify in regulation text our longstanding interpretation that the existing sections 440.90A and B are mandatory components of the clinic services benefit for states that cover the benefit, which those existing sections of the clinic services regulation address the physician direction requirement and the 4 walls exception for individuals who are unhoused. And to delete the word eligible from existing regulation text at 42 CFR 440.90B, because a state cannot cover a non-Medicaid eligible individual under the Medicaid clinic services benefit, so we felt the language is unnecessary. As mentioned earlier, CMS is proposing to make the IHS and tribal clinic exception mandatory and the exceptions for behavioral health clinics and clinics located in rural areas optional because the population served by IHS and tribal clinics more consistently meets the 4 criteria, both within and across states, than the population targeted by the optional exceptions, especially given the degree of state variability and whether the populations targeted by the optional exceptions meet those criteria. Additionally, our other rationales for proposing mandatory and optional exceptions include that Medicaid is the largest source of third-party payment for services billed by IHS and tribal facilities. There may be more geographic variability in the degree to which the population served by behavioral health clinics and clinics located in rural areas meet the four criteria. And finally, it is our understanding that Medicaid funding is less often the largest source of payment for behavioral health clinics and clinics located in rural areas compared to IHS and tribal clinics. We solicit comment on the arguments made in this proposed rule in support of the mandatory and optional exceptions, and on whether the optional exceptions should also be mandatory for states opting to cover the clinic services benefit. CMS is not proposing any additional exceptions to the clinic services four walls requirement, as it is our understanding that other populations are better able than those targeted by the proposed exceptions to access services through Medicaid benefits to which a four walls requirement does not apply under federal Medicaid law. In the proposed rule, we also invite comment on whether there are additional populations that are likely to meet the four criteria described in the proposed rule and that have no alternative access to services through Medicaid benefits not subject to a four walls requirement under federal Medicaid law, and on whether there are additional types of clinics that might serve as a proxy for such a population. CMS welcomes comments on our proposed rule. Comments are due September 9th. Please submit comments following the instructions in this Federal Register notice. I would like to emphasize again that nothing participants say during this webinar will be viewed as a public comment on the proposed rule. And with that, I will turn it over to Rachel as we move to our question and answer session.
Thank you so much, Ryan.
All right, so I do see a question here. When referring to the BH clinic exceptions in rural area clinics, are these exceptions available for non-IHS, non-tribal facilities?
That is correct. That is what we're proposing.
We have a question from Eugene. Does the federal encounter rate payment apply to Medicaid managed care organizations for Medicaid beneficiaries that receive services through a tribally owned and operated clinic?
I don't think we have anyone for our managed care team. That's not a question I'm able to answer. Rachel, is that something you know the answer to?
Well, so I think you're referring to, I'm assuming you're referring to the all-inclusive rate when you're talking about the federal encounter rate. Assuming that that's what you're talking about. We have lots of resources on managed care. So that's coming from Eugene. Maybe we can connect offline so we can get a better answer for your tribally operated clinics who are trying to get reimbursed through their managed care organization.
Great, thank you. Next question we have is from Amber. What is the definition of outside of the four walls?
Outside of the four walls would mean outside of the physical clinic or outside of the satellite location of a clinic.
Another question that we have received from Melissa. So private for-profit corporations in rural areas can receive the federal IHS tribal encounter rate?
So Ryan, you can correct me, but we're talking about the, I think that you're referring to the behavioral health in the rural clinics who could possibly bill outside of the four walls as an optional, and they would not be receiving the tribal all-inclusive rate. So that's just for IHS and tribal facilities.
Great. So I'll go ahead and ask the next question from Cindy. How will you advise states about the tribal FQHC provider type that some of them implemented to enable the IHS tribal clinics to bill outside the four walls?
Sure. And tribes can continue to be enrolled as tribal FQHCs. These are not, this regulation proposed is not intended to eliminate this option for tribes. If they've gone ahead and implemented the tribal FQHC option, they can continue to do that. It's an addition to that option that we provided. Great,
thank you. Another question from Cecile. Are house visits to homebound clients included?
That would be considered a service that's furnished outside of the four walls. So under under existing regulations, that wouldn't be allowable, but if the proposed rule is finalized, that would be allowable under the regulations.
And this question might be for you, Rachel. How can, from a question from Kay, how can they get a copy of the training? Will it be emailed?
We won't be providing it over email, but a copy of the webinar will be posted on our Spotlight page in usually about 2 or 3 weeks. So you can check back on our go.cms.gov/AIAN website under the Spotlight page for a copy of this webinar. And the slides will be included in that. It's like YouTube.
Great, thank you. Another question from Nevaeh. This only applies to behavioral health services and not any other health-related services?
So we're proposing three exceptions under this proposed rule. So there would be an mandatory exception for IHS and tribal clinics. There's no like requirement that it has to be behavioral health services for that exception. And then we're also proposing optional exceptions for behavioral health clinics and clinics located in rural areas. And we're also not proposing to require that the services be behavioral health services for either of those exceptions.
Another question from Grant. Would this allow for behavioral health clinics to operate in a school setting based and still bill under existing health centers?
I don't know about behavioral health clinics, but we do have, I don't see any reason. Katie, do you remember how we answered the question about the school-based?
No, why don't we take that question
Yeah.
back? Thank you, Grant, for asking it.
Great, thank you. Another question from Kathy. Does outside the 4 walls include physicians employed by the THPs providing services in local hospitals, such as delivering babies and etc.?
I think that would be inside the 4 walls, right, Ryan?
Well, so I get what is it? I don't know what a THP means.
Tribal Health Program.
Oh, gotcha. So is this a hospital-based clinic or is this a freestanding clinic? Because if it's a hospital-based clinic, that's not covered under the clinic services benefit. That would be covered under the outpatient hospital benefit, which doesn't have the outpatient hospital benefit does not have a 4 walls requirement.
So I don't think it applies.
Yeah,
right.
That's what I'm thinking.
A question from Sigrid. Will eliminating the 4 walls requirement for IHS clinics allow IHS clinic providers to bill for services provided to their patients in a hospital at the IHS rate? They're specifically thinking of an IHS clinic providers delivering babies in a hospital.
I think this is a similar situation, right? We're talking about hospital services. So the 4 walls requirement wouldn't have applied. And if we're not understanding that, please let us know, or we can follow up offline to make sure we're understanding that question correctly.
Great, thank you. Next question from Mark. Would services to Medicaid eligible non-beneficiaries, so individuals not American Indian or Alaska Native, by a tribal 638 facility outside the 4 walls be eligible for the all-inclusive rate 100% FMAP?
So as long as that person is served by the IHS tribal facility, we're including them in the exception.
Yeah, but for the FMAP rate the state gets, to get 100% FMAP, the beneficiary would have to be AIAN. If they're not AIAN, then it would be whatever FMAP rate is otherwise applicable.
From Antonia, would a tribal facility be able to bill for an OB provider, be able to bill for OB delivery in hospital once the 4 walls is included? And I think this would follow the previous questions that we have. And back to another question from Nevaeh. Will public health nursing home visits be part of the exception?
Nursing facility services are handled by a different team within CMS. So like this proposed rule we're talking about, it's specific to clinic services.
Great, thank you. And we do have a hand raised, and I want to make sure I give the participant a chance to unmute if they'd like to ask a question. So Tom, would you please be able to give access to James so that he can unmute his mic? Great. And James, you can press the unmute button and feel free to ask your question.
I think just to give some clarification on, I think, what the OB question is. So typically, I know in our facility, we do all prenatal care in one of our primary care clinics. However, we do not perform deliveries within our four walls. Our patients and providers, or our providers, deliver at another hospital where our providers have those privileges to deliver at. And I think that's what we're trying to find out is our providers are technically visiting another hospital to deliver that baby, but does that still allow us to then bill for that?
But is your clinic part of a hospital?
My particular clinic is part of a hospital, but we do not do deliveries
At that hospital.
at that hospital. We perform
Right.
all prenatal care. Deliveries are handled at a different hospital that we simply have privileges to perform deliveries at.
Probably a non-tribal hospital.
Correct.
And that would still not be, because the clinic's part of a hospital, that would still be covered under the outpatient hospital benefit, which does not have a four walls requirement.
Looks like there's several questions related to this like hospital question. So I think that discussion answers that question. If it doesn't, please let us know. Otherwise, I'm going to skip some of these hospital questions.
Perfect, thank you. And Tom, would you be able to unmute Dana? Dana has her hand raised and just want to give her the opportunity to go ahead and unmute. Dana, you should be able to go ahead and press the unmute button on the bottom left of your corner. You can ask the question now.
Okay, great. Can you hear me?
Yes, we can.
Okay,
Yes.
great. Thanks. Thank you. So when CMS first kind of discovered this discrepancy, they advised states to, in order to allow ITUs to continue to bill outside of four walls, they advised the states to have to deem the ITUs as a FQHC. So will that continue? Does that designation still need to continue, or will the states be advised to kind of, I guess, disregard that, or what becomes of that?
Sure. So
Thank you.
if you've already gone through the process of having them designated as tribal FQHCs, they can stay that way. It doesn't affect the exception, but it's not required anymore. Or not that it was ever required, but it's not necessarily needed to be exempt from the four walls requirement.
But
Does that make sense?
But this is Kitty. I mean, if tribes still have the option to continue to be a tribal FQHC, there
Right.
might be other reasons why they would want to continue to be a tribal FQHC and receive the IHS all-inclusive rate. So by issuing this regulation and making an exception for clinics, we're not removing that option for tribes to be a tribal FQHC.
Great, thank you. And Tom, would you be able to unmute Antonia? She has her hand raised. Great, Antonia, you should be able to go ahead and click the unmute button on the bottom left of your screen to ask your question.
In regards to the OB question, those of us in California do not have hospitals that we are affiliated with. We are tribal entities by ourselves. So our questions are, can our OB providers who go to the hospital to deliver a baby, can we bill for that service because it's outside of our four walls?
Hey, this is Kitty Marks. Maybe we can take this question back. I don't think that we have the subject matter experts. It's really a different question outside the clinic benefit, and it might depend upon how and what arrangements the tribal clinic has with the local hospital. If you could identify who's asking the question, or if you'd like to send that question to our tribal affairs box at tribalaffairs at
I'm putting it in the chat.
.hhs.gov. And then we can research that and get back to you. Yeah.
Thank you.
Is that helpful? Okay, thank you.
Thank you, Antonia. I'll read the next question that we have in the Q&A box from Sadie. Since the rule applies to IHS clinics, will the states have the final determination as to what services can be provided at the outside of the four walls? Or will it be all services identified within the tribe's annual funding agreement or contract with the IHS?
I believe that this will apply to all of the clinic services benefits, right, Ryan? So anything that would be considered a clinic service, not necessarily within the confines of what's in your funding agreement.
Yeah, this isn't something we addressed in the rule, but that sounds right, Rachel.
Mm-hmm.
Great, thank you. A question from Anthony. Does outside the health of the four walls cover a BIA IHSPL funded emergency use shelters?
I'm guessing not without more information, just because I don't think that would qualify as a clinic. But if you are a clinic, then it would apply. And then we might need more information, or if you're not sure, you can get a hold of us again using the Tribal Affairs mailbox. Maybe we can help you run that down.
Great, thank you. Question from Curtis. To piggyback off Nevaeh's comments about behavioral health, will mobile behavioral health services be a part of the exception as well? So that's more of the community-based services.
So, like I indicated earlier, one of the exceptions that we're proposing is a state optional exception for behavioral health clinic services. So if the mobile behavioral health provider is falls under that exception and we finalize the rule and a state adopts that exception, then yes.
Great, thank you. Question from Kathy. In California, we do not have tribal run hospitals. Our providers provide professional services to our patients at local hospitals that are not part of our tribal health program. We want to know if we can bill for our services provided outside the four walls to deliver babies and provide other necessary professional services. And I think this was mentioned earlier that we will have to look into this more to follow up. Is that correct, Rachel?
Yes. I don't know if Kathy, I'm sorry, I missed the name of the person who spoke up and asked that question verbally. So I don't know if you're from the same organization or if this is just a question that seems to apply to all of our California providers. So if one or all of you are welcome to submit that question to the Tribal Affairs mailbox, we'll look that up. And I do see the other question about whether or not that's going to be sent out to all attendees on the call. I don't know, Nicole, how we usually handle the follow-up to the questions, but we do have a record of these questions, right? And associated email addresses.
Yes, we will.
Okay.
And I'll leave these questions open so that you guys can follow up with them. So I do not see any additional questions in the Q&A box, but I do see a hand raised from Monica. Tom, would you be able to help unmute? And Monica, you should be able to press the unmute icon on the bottom left to ask your question.
Thank you. Can you hear me?
Yes, we can.
Okay, can I just clarify on that follow-up to my question that was in the Q&A? So are you suggesting that I send the same hospital question to the Tribal Affairs email to ensure I get a response back?
Well, I do think we have a list of the questions and we can track them down, but it would just be helpful since this sounds like a complicated issue, if we can maybe just work directly. I monitor that email box. So if you send that to the Tribal Affairs mailbox, then one, it helps us get a written account of exactly what the issue is. And then we can work out an answer. We can maybe ask you follow-up questions. It just helps sometimes to have, more of a dialogue. Yeah, if you don't mind.
Okay, thank you so much.
Great, thanks. We do have a question that came in from Dana. When will this rule be implemented, and will the states get a DSMD letter?
So like I had indicated earlier, this is a proposed rule, so some things are still subject to change. The public comment period ends September 9th, but the OPPS ASC rule does have a statutory effective date required in federal law of January 1, 2025.
And that also, for those of you who are familiar with the grace period extension, so that will lines up with the grace period extension.
Great, thank you. So I do not see any questions in the Q&A box or hand raised. So again, if you would like to ask a question, feel free to select the Q&A box located at the bottom of your screen. Or you can also use the raise hand icon and we can get to as many as we can.
I do just want to say, Grant, I know that you sent in, I'm seeing your question about school-based, and we said we'd follow up. If you wanted to send that to us to the Tribal Affairs mailbox, that would be great as well. So again, we can follow up directly with you with questions or clarification, since that was one of the other questions we weren't able to answer on the call.
Great, thank you. Are there any more questions? Great. Question from Curtis. How does this affect substance use disorders or OUD treatment and peer billing for tribally operated facilities?
So I'm not sure, Ryan, if you have any more insight about that. I think
No,
if
I
you're
don't, unfortunately.
okay, sure. So so Curtis, if you're billing for those services through your clinic and you're providing them outside the four walls and you weren't able to receive the all-inclusive rate for those before, then this would apply. If I'm not understanding the situation correctly, please follow up and let us know. I'm not sure about the peer billing, if that's something that you would be receiving, you know, the rate for, and now that the exception applies, you can continue that and won't be expiring with the grace period. If that's not quite right, what I'm understanding from your question, just let us know.
And he did clarify, we do not contract our IHS facility, but we contract through the recovery PFSA from IHS.
I am not really sure. Kitty, do you have any insight on this, or is something we need to follow up on offline?
Yeah, I think this might be outside of the four walls clinic benefits. So Curtis, again, if you could send your question to tribalaffairs@cms.hhs.gov, and we can follow up with you. Thank you.
And I just put that in the chat again, so everybody should be able to see that.
Great, thank you, Curtis. Are there any more questions? So it looks like there are no more questions at this time. I will send it back to you, Rachel, for any closing remarks that you want to go ahead and take over.
Thanks. We just want to thank you all for your participation and remind you that a copy of the webinar will be found on our Spotlight page, our website, go.cms.gov/AIN. You can also go under the All Tribes Call tab, and it should be there as well. And again, like we've talked about, you can always submit your questions to the CMS Division of Tribal Affairs after the webinar if you think of anything or have any clarifying questions, tribalaffairs@cms.hhs.gov. And I also want to remind you that written comments to the proposed rule are due on September 9th, and we ask that you submit those comments by following instructions in the Federal Register notice. Thank you again, and we hope you all have a wonderful afternoon.